show you how nice access is retroperitoneal access. Maybe you are not performing too much retroperitoneal access, this transperitoneal through abdomen or retroperitoneal from behind. As you know, all the urological organs are in the retroperitoneal area. Means that if you want to operate, you have to go to retroperitoneal area. If you have a retroperitoneal access, then you can go directly to retroperitoneal area. Next slide. This is our clinic. Next slide. Okay, just I don't know if you can see, let the video run.
Yes.
This is a transperitoneal access, and these are the bowel. You see. I hope you can see. Looking like this. This is the surgeons preparing the bowel. Bowels to be prepared. And oh, this is the, you see, is a hole there. This is a hole, and this can happen if you work transperitoneally and the bowel is stuck. When you are going to prepare the bowel, you see, then now you have you see there's a hole in the bowel. You are working laparoscopically. You have to wash first everything. It is in the column, you see. And thereafter, you have to close it, if you can. If you cannot do it, you have to open the patient. If you are operating as you can, if you can prepare it. But if you are operating retroperitoneally, this will never happen. You will never see this problem when you are going to the retroperitoneal way. And actually the message is, if you go retroperitoneal, the bowel injury will be less or almost zero. This is the most important advantage of the retroperitoneal surgery. You see here, you can close it with stitches. If you can. If you cannot, you have to call the surgeon. Then surgeon will open the patient. Then your operation will be from the beginning not very good. So better take the retroperitoneal way. Next slide. As you see, then how the retroperitoneoscopy in laparoscopy started. First time in here, the 74 is the biopsy, and then 79. First retroperitoneal ureterolithotomy, then 99, first laparoscopic nephrectomy, retroperitoneal, and then slowly, then 92, this is the balloon preparation has been described. You see, this is the retroperitoneal. Next slide. Please stay here. This is the kidney. If you go to the kidney, you don't need to go here. It's always a short way to go to the retroperitoneum. Next slide. These are how you can go to the retroperitoneum. Next slide. There are two approaches. You can put the patient like this, or like you are doing every day on the lateral. When you are operating the patient, normal nephrectomy, open case, you are putting the patient in the same position. Means the lateral flank position. Next slide. How you will do the access, how you will go to the retroperitoneum. If you know the anatomy, everything is easy. As you see, these are the muscles on the retroperitoneal posterior side, and then you have to know the landmarks, where are the ribs, where are the muscles, then where you have to enter your first trocar. Next slide. As you see here, 12th rib is very important in this anatomy, because you have to put your first trocar on the tip or just below the tip of the 12th rib. Next slide. These are the anterior axillary line, medium axillary line, and posterior axillary line. As you see, this is on the posterior axillary line, just below the 12th rib. The first trocar will come. Next slide. This is actually, we have described this in the book of the laparoscopic anatomy. This is the optic trocar. This is the here ribs. Then this is the here posterior axillary line, medium axillary line, anterior axillary line. But I have a video already. These are the indications for what you can use the retroperitoneoscopy. Almost for every laparoscopy indication, almost, you can use the retroperitoneoscopy. Next slide. This was in 2006. We have started with retroperitoneoscopies 1992. Till 1992 till 2019, almost 30 years. Almost 30 years we are performing retroperitoneoscopic surgery for the kidney and ureter. Next slide. For the indications, as you see, as we have published this almost more than 10 years ago, 13 years ago, this is the approach is working very, very excellent. The most important thing is when you are going transperitoneal, you have to work on the colon, open the gerota, find to the ureter, go to the hilum. But if you are doing retroperitoneal, you will see direct to renal hilum, as I will show also in the video. These are our cases in 2017. We had more than 2,000 cases. I think now 2,500, maybe 3,000 cases we have. These are the indications. Most of them we are performing almost all the nephrectomies retroperitoneally. Most of the nephroureterectomies, partial nephrectomies, renal cyst, pyeloplasty, adrenectomy, retroperitoneal lymph node dissection, or almost all the ureterolithotomy cases we are performing in retroperitoneal way. Next slide. These are the other less indications. One more. Next slide. Sure. Retroperitoneoscopy is very good, but there are some indications you need transperitoneal access. For the very small children, the tumor is very big. The renal tumors is ventral localized. If it's the intra-aortocaval lymph nodes, or if it's a horseshoe kidney, then it's a transperitoneal access is working better than retroperitoneal access. Next slide. What is this? Okay. Difficult procedures. I want to just give the message that you can perform easy or difficult all these cases via retroperitoneal way. Next slide. Okay. What are the contraindications? In which cases you have not to do the retroperitoneal access? This is if the malignancy is very advanced and already infiltrating, for example, psoas or the other organs. The tumor is very big. If you have done xanthogranulomatous pyelonephritis, is this the post-traumatic case or post-embolization case, or if the patient had already a retroperitoneal surgery, everything will be very, very stuck. Next slide. Where we will go one more time, you see here the muscles, but it's better to see in the video. Next slide. I hope it's working. Yes. This is the patient position in the lateral flank position, as you can see. And like you are doing open cases, it's the same position. We have a balloon, or we have to open the patient to reach better the area, because you have to open the area. Okay, let's run the videos. I hope the